The next speaker, Dr. Manas Kumar Panigrahi, and he will talk about posterior approach to craniovertebral junction. Please, Dr. Panigrahi. We are not listening.
Okay, can you hear me?
Yes, perfect.
Please start from the beginning. We didn't,
Yes.
we couldn't hear you.
Yeah, good evening. Sorry for the hiccups, of the technical hiccups. I'll be speaking on the posterior approaches to the cerebrovascular junction tumors. And Dr. Abida has already stressed that all of them can be done through the posterior approach. But in my 15 minutes, I'll explain which are the cases one has to do through a posterior approach and which are the cases probably one needs alternative approach. As all of us know that the foramen magnum tumors are tumors which involves the lower part of the clivus till the upper border of the C2 body anteriorly and posteriorly from the rim of the occipital scama to the upper part of the C2 lamina and laterally from the jugular tubercle till the C2 lamina. Now, these are any tumors arising or attached in this region is called as foramen magnum tumors. So they can be classified into anterior or anterolateral or posterior depending on the attachment in relation to the dentate ligament. Any tumor in front of dentate ligament is an anterior, and if the tumor is attached ventrally to the midline on either side, it's called anterior. But if it's attached from midline till the dentate ligament, it's called anterolateral. And if it's behind dentate ligament, it's called posterior and or posterolateral. This is more important in meningioma, but also it's important in neurinomas and neuroenteric cysts also. Now, lesions in the foramen magnum, fortunately, most of them, like 50% of them, are posteriorly located, either posterior or posterolateral. So they can be operated with a posterior approach. But then only 20% are purely anterior and 24% can be anterolateral. So this 40% group, one has to think whether they can be done through posterior approach or one has to have an alternative approach for these cases. Unlike meningiomas, 80% of them are attached anteriorly or anterolaterally, and we have a separate lecture on foramen magnum meningiomas. But as a general rule, when you take all the foramen magnum tumors, 50% of them are behind the dentate ligament, so they can be operated through the posterior approach. If one looks at the different surgical approaches of the tumors of the foramen magnum, there are many approaches described. The posterior approach, the lateral approaches, and the anterior approach. But then anterior approach is not very popular because it's the chances of infection is higher, the CSF leak is higher, and it is restricted by if the tumor is extending laterally beyond the internal carotid, then one cannot excise ventrally. But with the use of endoscope, few cases, especially extradural tumors, people have tried doing with an anterior approach. many people have tried with transcondylar, extreme lateral, mobilizing the vertebral in different approaches, having difficult approaches. But Professor Atul Goyal in 2001, he said that most of them can be operated through a posterior suboccipital approach. And he said that we do not need to struggle with different approaches. We can do with a posterior approach. But then one has to look at the meta-analysis and decide which cases actually can be done through the posterior and which cases one needs to do the posterolateral approach. Now, this was a review came in 2023 of the different surgical corridors for foramen magnum tumors. And in this, basically, there are three different approaches. One is midline suboccipital, one is the lateral approaches, and one is the ventral approach or the transversal approach. Now, there are many variations of the posterolateral approach, like occipital, transcondylar, supracondylar. You have transjugular process, transtubercular, paracondylar, and some people have done it by preserving the bone also without doing laminectomy or without doing suboccipital craniectomy. They work in between the lamina to preserve the bone and take out the tumor. Unfortunately, the tumors of C1, C2 behave differently than tumors in the cervical spine, because cervical spine has a lateral mass and reaching the posterolateral is difficult. Whereas in C1, C2, because of the ganglion, you have a wide area, there is no lateral mass there. So one can still do many approaches with just posterior approach. As Dr. Abhida was explaining, that if you have a neurofibroma of the C2, it can be done with just a posterior approach by following the plane or the interdural plane. Is the anatomy which helps us to decide whether to do a posterior approach or a posterolateral approach. Now, there are this systemic review in 2021. When they analyzed all the foramen magnum meningiomas starting from 1996 to 2019, many people have used all types of approaches, starting from midline posterior fossa to extreme lateral approach, far lateral, transtubercular, transpetrosal, and it is confusing for a surgeon who starts practicing which is the best approach. We also published our results of the need of condylar resection, and over a period of time we realized that condylar resection is not required, and most of the tumor can be done through a posterior approach, and one has to understand the need of condylar resection depending on the extent and the consistency of the tumor. So how do you decide the best approach for a particular tumor? Now, the best approach can be decided by visualizing the scan. If one does a posterior fossa, midline fossa suboccipital craniectomy, if the tumor is seen on the surface, there are different corridors. Like if the tumor is seen either between lateral to the vertebral artery, or if the tumor is seen between the vertebral artery and the medulla, or the tumor is seen above the C2 nerve roots and below the C1 nerve root, or lateral to the spinal accessory. These are the four corridors. If the tumor is seen, all these tumors can be done through a midline posterior fossa. One need not do a extreme lateral or far lateral approach. Now, this can be visualized by studying the radiology properly. Like this patient, this patient has a posteriorly and posterolaterally located. This can be done easily through a posterior approach. Like this, again, the tumor is pointing on the surface. So if one does a posterior fossa craniectomy, though that attachment is ventrally, but the tumor is pointing, pushing the cord. Again, this can be done through a posterior approach. Like again, this case, though it is attached ventrally, but the tumor is pointing in the cerebromedullary fissure on the surface. One does a suboccipital craniectomy, one can see the tumor surface without any retraction of the brain stem, and these tumors can be done through the posterior approach. But if the tumor cannot be seen on the surface, then one has to have an alternative approach. So to decide what is the best way, we classified the tumors depending on the location, whether it's anterior attachment or lateral or the posterior attachment, and the extent of tumor, whether the tumor is purely interdural or a purely extradural tumor, or the tumor is a combination of extra or interdural combination. I'll give example of each one. Like this patient is a purely anterior tumor intradural. This intradural tumors are not good for a transfer as it is seen posteriorly. It is better to do a posterior approach. Whereas this tumor, which is purely anterior, which is an extradural tumor, very small intradural extension, and this has to be done through a anterior approach, and we did a high cervical extrapharyngeal approach. Compared to this tumor, which is laterally located, this is purely extradural tumor, and going into the neck, whereas this tumor is a laterally situated tumor, but has both an intradural component and an extradural component, and this needs a different approach. I'll be explaining what is the best approach for this kind of tumors. So if a posteriorly located, one do a posterior approach, and if it's a combination of intradural and extradural, one can do a posterior approach, do intradural dissection of the tumor and remove the tumor. So midline suboccipital is done for posterior lesion, whereas for combined intra and extradural, one has to do a far lateral approach. For anterior intradural is a far lateral. For anterior extradural, it's a high cervical extrapharyngeal. And when it's a combined intra and extradural, one has to do a combined craniocervical approach. So basically, three types of approaches are required: high cervical extrapharyngeal for anterior extradural, for posterolateral situated is a far lateral, and a combined craniocervical approach when there is a combination of intradural and extradural tumor which is present in the lateral compartment. Like this tumor, the tumor will be seen when you do midline suboccipital craniectomy. One can see the tumor here, though the attachment is ventrally. It's a good case for midline suboccipital. Again, this case, it will be seen if the tumor is seen on the surface. It's a good case for midline suboccipital. And again, this case, the tumor will be seen in the cerebellomedullary fissure when you do a midline suboccipital, and it's a good case for midline suboccipital. Whereas this case, where there is a neural tissue covering, it cannot be done through a midline suboccipital. One has to do either a far lateral or an extreme lateral to have an excision of tumor. So this patient we do with lateral position. This is the incision we do. We reflect the whole flap as a single layer, not with three layers, and then do a retrocondylar dissection. The posterior third of the condylon is dissected till the condylar vein is reached. And the dura is reflected laterally. And then the vertebral artery is identified, and the tumor is identified there. This is a spinal accessory, the C1 nerve root. This is the tumor. This is arising from the vertebral artery. The dentate ligament is incised to identify the vertebral artery. And tumor was adherent to the vertebral artery. It was detached using a thulium laser to devascularize the tumor. And tumor was taken out in piecemeal as it was very highly vascular, detaching it from the vertebral artery. After it was detached, then internal decompression was done with the laser. The laser has a small footprint. It's easier to do hemostasis rather than using a bipolar. And then the tumor, the capsule was dissected from the brainstem. Intermittent decompression and dissection was done. And finally, the tumor was removed. So this case cannot be done with a midline posterior fossa. One has to do a paralateral approach. And finally, the dura was closed. So these are the still pictures of the case. But this is whereas this case, which is has both an extradural component and an intradural component, you can see here that the tumor going through the jugular foramen, going outside, or preliminary diagnosis and coming down till the neck through the jugular foramen. Our diagnosis was there was a paraganglioma. Embolization was done with preoperatively, and tumor blast was reduced. And this is how the patient was positioned. And this is how the incision is done when we plan to do a craniocervical approach to expose both the cervical part as well as the intracranial part. We do a posterolateral approach without mobilizing the facial nerves to prevent facial nerve palsy. Like we save the facial nerve in the canal. We work posterolateral to the facial nerve to the transjugular process approach, expose the whole sigmoid sinus, the jugular bulb, and the internal jugular vein, and then deliver the tumor from inside the sigmoid sinus by cutting the sigmoid sinus, and deliver the tumor from the jugular vein by cutting the jugular vein. So this is the part excision from the section of the neck. Mastodectomy is done to skeletonize the whole of sigmoid sinus and the transverse sinus. Then the sigmoid sinus and transverse sinus junction was a temporary clip was placed. Then sigmoid sinus was opened. And the upper pole of the tumor was delivered from the transverse sinus. Then the internal jugular vein was dissected in the neck, again ligated from below. An internal jugular vein was opened up to take out the tumor from the jugular vein. One is to follow the tumor, preserving the wall of the sinus to prevent damage of the lower cranial nerves. If one remains inside the wall of the jugular vein, the chances of damaging the cranial nerves are less. And then the sigmoid sinus and the internal jugular vein are connected by unlocking at the level of jugular bulb. After the extradural part is removed, the dura is open to take out the interdural part of the tumor from the CP angle. Is it, in spite of embolization, it was vascular, but hemostasis could be achieved by just packing with a fat wrapped with fibrilla. And this is at the end of excision of the tumor. And the gap was filled with fat and closed. So these are the picture steps of surgery. I've done that. The video doesn't open to show the steps of surgery. And this is the post-op scan. Some residual tumor is there, and the patient is under follow-up. This is another case of a glomus. Again, both intra and extradural component. And this is a post-op scan, and without any facial palsy. Whereas tumors like this, which are anterior anterolateral located, purely extradural, presenting with hypoglossal palsy, one has to do a tumor like this, which is extradural, one should do a high cervical extrapharyngeal approach by L-shaped incision. Exposure is similar to the anterocervical discectomy. The hyoid ligament and the hyoid muscle is divided from the hyoid bone, so that the pharynx can be retracted medially to expose the the tumor, and this is the tumor which has given yellow fluorescence. One can see the green color. The tumor was excised. This is the fluorescent tumor, and this is at the end of excision of tumor. So the commonly used approaches are for posterior lesions, a midline posterior, midline in suboccipital approach. For anterior intradural lesions, one has to do a paralateral approach. For anterior extradural lesions, a high cervical extrapharyngeal approach. And whenever there is a combination of extra and intradural lesions, the lesions going to the neck, a craniocervical approach is helpful. In conclusion, condylar resection is not required in any of the cases. One is not be dogmatic that all the cases can be done through a posterior approach. The approach is customized depending on the extent of the attachment, the consistency of the tumor, and whether the tumor can be seen from the posterior approach, and one has to visualize it from the MRI, whether the tumor, any surface of the tumor is seen between the neural structures or through the four corridors I explained. Those cases can be done through the posterior approach. Other cases, one has to do a paralateral or extreme lateral or a high cervical extrapharyngeal approach in tumors of the foramen magnum. Thank you for your attention.
Thank you very much, Dr. Panigrahi. Excellent presentation. And the next speaker is